Taking advantage of the most advanced data processing techniques, we present a virtual transcanalicular and endonasal diode laser-assisted dacryocysto-rhinostomy in order to provide a spatial view of the basic principles of this procedure on the excretory duct of the lacrimal gland. Opening the lacrimal sac, drainage to the nasal cavity, and restoration of normal tear function. Failure of the tear drainage system leads to epiphora and repeated infection, which could jeopardize the integrity of the orbit and eyeball. With the use of endoscopy and the diode laser, we modified the original surgical technique to obtain a minimally invasive procedure for the lacrimal excretory system. This is done on an outpatient basis with topical and local anesthesia. The local anesthesia, a mixture of 1.5 milliliters of mepivacaine 2% and 1.5 milliliters of bupivacaine 0.75%, is infiltrated in the nasociliary area, blocking the infraorbital and infratrochleal nerve with 1 milliliter of anesthesia in each area. For the topical anesthesia, a cotton swab is impregnated with a mixture of tetracaine 1% and epinephrine 1/100,000th and placed in the nasal fossa about 15 minutes before surgery. The upper lacrimal punctum is then dilated and an optical fiber is inserted and advanced along the anatomical pathways through the superior canaliculus, common canaliculus, and lacrimal sac, entering into contact with the medial wall of the lacrimal sac, confirmed by the hard boundary of the lacrimal bone. Laser energy is then delivered in pulses until the fiber passes to the nasal fossa. Under direct endoscopic visualization, the initial osteotomy is expanded by transcanalicular route in the antero-inferior direction by juxtaposition of converging bursts in the form of a circle. Another option is to expand the initial osteotomy by the endonasal route. The nasal mucosa is first coagulated with continuous mode laser energy and no contact. Then antero-inferior excision of the bone tissue in the ascending apophysis of the upper maxilla is performed with the laser in contact mode and pulses. Finally, bicanalicular intubation with PVP-coated silicone tubing and proline thread is carried out, aided by the guide wire. The mean surgery time is 10 minutes. The intubation is withdrawn after 1 month. Transcanalicular and endonasal laser-assisted dacryocysto-rhinostomy offers a series of advantages. It does not leave a skin scar. Disinsertion of the medial canthal tendon or incision in the orbicular muscle is not required. And there is no injury to the angular vessels or bone fracture. Furthermore, bleeding and intraoperative and postoperative pain is minimal. Surgery time is shorter. General anesthesia and hospitalization are not needed. Postoperative morbidity is low, and resumption of daily activities is rapid. Advanced techniques in laser-assisted dacryocysto-rhinostomy. We are now seeing considerable advances in surgery using minimally invasive techniques that reduce surgical trauma and allow fast, smooth patient recovery. Because of the reduction in operating time afforded by the laser, dacryocysto-rhinostomy can be performed with topical anesthetics applied to the eye surface, excretory lacrimal duct, and nasal cavity. Local regional injections are not needed, and this contributes greatly to alleviating the patient's anxiety and reducing intraoperative risk and postoperative sequelae. To avoid complications, we do not use a metal guide wire to orient the laser fiber because of the retrograde diffusion of the thermal energy produced by this material. This overheating would cause secondary burns in the canaliculi, lacrimal puncti, and eyelids. Hence, we use only optical fiber with flexible silica or fluoropolymer cladding, shown to be resistant to high temperatures. Depending on their diameter, optical fibers require power adjustment, since the energy density increases exponentially as the diameter decreases. The ideal compromise between risk of fiber breakage and maximum energy concentration in the fiber is around 400 microns. From this point onward, the risk of breakage increases as the concentration increases, and vice versa. Fibers of 600 microns allow us to overcome mucus or fibrous obstructions upstream from the lacrimal sac, and are easier to handle and position when delimiting the ideal area to create the new opening. The key to this technique consists in firing the laser pulse only after confirming the position of the laser fiber by transillumination through the bone with the nasal endoscope, thereby avoiding false pathways and iatrogenic lesions. A power setting of 8 to 12 watts will give fast, deep incisions. A pulse width of 50 milliseconds will give gentle, precise incisions. Increasing the laser power above these levels will produce iatrogenic burns. For a faster effect on tissue at the initial contact, it may be useful to establish a microcarbon plane on the tip of the optical fiber by first firing the laser on the test material. Another complication we describe is lateral displacement of intubation. This can be easily resolved with the endoscope and is relatively unimportant if the tubing is withdrawn early and periodical washing is performed. We suggest early withdrawal of intubation at 3 weeks to prevent granulomas and duct laceration, and to obtain the best possible outcome. The success of this technique is between 63% and 90% according to various authors. The most frequent causes of failure in dacryocysto-rhinostomy are scarring of the soft tissues surrounding the surgical fistula, synechia of the nasal mucosa, inappropriate size, particularly if the initial opening is less than 5 millimeters, and inadequate location of the osteotomy, which ideally should be at the level of the common canaliculus. The result of these factors is closure of the osteotomy. We have recently begun using mitomycin, as it has a potent inhibitory effect on fibroblast proliferation of the soft tissues surrounding the area of the new osteotomy. Apart from these innovations, our line of research is currently looking at obtaining tissues that allow maximum absorption of the light energy delivered by the diode laser, thereby enhancing its action to allow shorter exposure times. The purpose of our work in the treatment of the lacrimal system is to identify techniques that are easier to perform and less harmful for the patient, using the innovations provided by endoscopy and laser technology.